series entitled Trans Tasman Knowledge Exchange on Pandemic Awareness and Effective Collaboration. I first of all like to welcome our panelists for the second webinar in our series. Unfortunately, a couple of our panelists couldn't make it this evening, and they had family and a hospital situation at the last moment, so they are unable to join us. But first of all, kia ora, Kerri Nuku, from the New Zealand Nurses Organisation, and Thijs de Blok from Buurtzorg, covering Japan, APAC and the Netherlands. First of all, what we're going to do is, while we want to keep the webinar conversational, we're just going to kick off with a quick presentation from Jorn. At S23M, we believe strongly in co-design and collaboration, and that the patient experience would be greatly improved for patients, the nurses and the clinicians if software that was developed together with the users. So Jorn Bettin is going to give us a short demo of our collaborative approach, and then we'll go on to talk about the topic tonight, which is establishing effective long-term collaboration patterns with the providers of managed isolation and quarantine services and other non-healthcare organizations. So anyway, you take it away, Jorn.
Okay, yeah, I'll hope to keep this brief. Yeah, since Kerri, I think we haven't yet met, so I thought it's perhaps worthwhile providing you with a short introduction what S23M is about. So we're a small company originating in New Zealand back in 2002. So we've been around for a while. We have done a lot of work internationally, and we now operate out of New Zealand and Australia, and we've got 2 partners in Europe, in Germany and Spain. But overall, our team is still less than 10 people if you count the core team. Having said that, we have a joint venture with a technology partner in the Philippines. So we've got a very significant software product development capability, and we've got interesting product lines for the wider healthcare sector. But beyond software, we're really interested in enabling knowledge to flow to all the places where it can be put to good use. And in the context of healthcare, this relates to community-oriented and patient-centered health service co-design. So these are the services that we offer in the healthcare space. And let's hone in on the first one there, which is the community-oriented and patient-centered co-design. This is a variation of our baseline service, which we call creative collaboration, which consists of open space workshops on a regular basis. In the healthcare space, we are in the process now of launching this new variation of that service specifically for the healthcare sector, together with Figure NZ, who you may be familiar with. So they're another small organization that's been around for a while. Their focus is on making data resources available for the public good, making it easy for people to access and use data for the public good, and giving people control over the data they produce. Yeah, this fits extremely well with our focus on catalyzing knowledge flows, and with our visual semantic modeling capability, and also with the cultural things that we are involved in the healthcare sector. So for the last few years, we've been sponsoring a sector-wide anti-bullying initiative. Trust is absolutely critical in this context. So this comes down to having appropriate data governance frameworks and software tools that are explicitly designed from the ground up to support trust building and communication. The idea is to empower patients and their families to grant and restrict access to selected information artifacts, and also to allow patients to provide feedback and ask questions as needed, and to allow them to monitor all access to their health data. So open space workshops are at the core of what we do there. So this is all about surfacing unmet needs in communities. That's obviously the starting point. And then together with communities, we're able to engage with healthcare providers such as DHBs to then work on solution designs. And in this context, we draw on local domain expertise in terms of healthcare professionals, local community representatives, and also experts from Figure NZ regarding data visualization and publication. Well, community nursing experts. So Thijs with Buurtzorg. I mean, if their expertise can be of value, I'm sure that there are perhaps ways of tapping into this. So it's all about collaboration. In New Zealand here, I think such community-oriented service design needs to be Māori-led. So we are very well familiar and aligned with the design justice network principles, which I think are a useful tool for appropriate inclusion of various minorities. So within our team, we've got a lot of neurodivergent people. So I myself identify as autistic. So we've got experience in with intersectionality and coordinating collaboration amongst different minority stakeholder groups. So Māori knowledge is important in this context. Māori engagement models, whānau needs, the treaty, of course. And what we bring, we combine this with the thinking tools of our methodology, so which is based on various scientific disciplines and engineering and design disciplines. Now, I don't want to keep this too long here. Just briefly, the patient journey management software or care platform that we provide is intended for integrated care, so can be used in the context of hospitals, allied health services, home care, and care homes. Interesting aspect here is that, well, the whole thing is, of course, multilingual. So this may be an interesting topic as well. So what we've discovered in the design of our software is that the Ministry of Health here in this country is only at the very beginning of establishing Māori as in terms of health information standards as a language. So I think the terminology still needs to be translated to a significant extent. Our software is equipped from the ground up to do this, and we are in the process now of engaging with the Ministry of Health to see how we can assist them in this context. So in concrete terms, well, you can see here our software. We talk about patient journey management. So there's here at the top, these menus. This is the daily functionality that people need in the healthcare sector, all about referrals, patients, appointments, staff, management of equipment. Then here, collaborations, we have that as a separate section. So to match supply and demand in highly dynamic contexts like the pandemic. So this is a new feature that we've added recently because The situation in different geographies changes, of course, on a weekly basis, and you need to be able to react to this. Not everything in this context then fits into the nice business as usual referral process. What I wanted to focus on here briefly is just what comes out of the box, all the stuff that is part of our care platform. To perhaps illustrate how we are equipped to deal with multilinguality and different cultures. So every user, whether it's a patient or a clinician or health professional, can nominate a preferred language and a second language. And then the system here, as you can see, we support various languages and technical terminologies. So we distinguish between these base languages and then highly formal technical terminologies. So just to illustrate, here in New Zealand, we basically are dealing with two languages, so Maori and English. In other countries, there would be corresponding differences. So here we can see that in every language, basically you can define or attach labels to all the concepts in the, not only in the application, but also all the concepts at a data level that relates to the SNOMED CT standards that define the language used by health professionals. So that's, I guess that's all that I wanted to show, really. So let's get going with our main session. I'll hand back over to Pete.
Great. Thanks, Jorn. Yeah, I don't have too much to say. As I said, what I would like to do here is to really keep the panel conversational, and so you know, as you both come from nursing backgrounds, but from different geographies and different contexts, I thought that could be quite interesting. So I was going to kick off with whoever wants to answer this is looking at to what extent you think that your organization, either informally or formally, establishes new collaborative partnerships with non-health organizations, because obviously because of the pandemic and managed isolation and quarantine, that has pulled in a lot of people who are not healthcare professionals. So I was wondering just how you might be dealing with that.
I can start if you like, because I think it's important to get some context on the differences between New Zealand and Holland. New Zealand, as it is a lot of difficulties with being an island far away from everything else, but there's also certain advantages. First of all, I've been following the procedures and policies in New Zealand closely, and I must say they've done an excellent job at stop the virus from spreading in every way they can, and also to be public about it and let the public enjoy also the success in this approach. So I think that's really good. In Europe, this is slightly more difficult because it's been since the 80s since we had border closings. So a lot of authorities and police forces have been called in upon to make this possible, but it's not airtight. So in Holland, they've decided to not oppose a mandatory quarantine. So it's an advised quarantine, and with this, you have to naturally collaborate with all the institutions that come with it, whether it's the naturalization and identification services, or it's the police, or it's the military police, and everyone has to be involved and everyone has to understand the benefits of restricting yourself from contact for 2 weeks. Our nurses play their usual role in this in the Netherlands. So they are well-known figures within the community, and they try to advise the formal and informal networks of clients and family members around them. So we try to pull our weight in this, and also give our nurses some education on this behalf. So we hired an epidemiologist to give all our staff the proper education on how it can affect the public health if we don't pull our weight. And this has led to the result that everyone wants to collaborate with us on this behalf, and this has been very inspiring. So this is some background on how we've tried to do it. No system is perfect. There's always gaps, and things may happen. So we've seen a certain surge in cases in Europe, but also in the Netherlands. And I think with the information that we've gathered so far, we can prevent the public health from a second spike in coronaviruses.
Kerri, maybe you could give Thijs and the audience a little bit of a who are your members, and what sort of services do you cover?
Sure. So our organisation is both a union and a professional body, and we are the biggest nursing group in the country. And we represent about 51,000 members, of which they work across a diverse areas, from primary healthcare, community aged care, palliative care, and in our big district health board structures. So they are very varied, but our organisation also represents nurses, healthcare workers, students, and midwives, some midwives. So our representation is very wide, which is why when we went into COVID and our level 4 restrictions under a national state of emergency, we were very forthright in coming forward to protect our essential workers, because there was constantly the cry for lack of PPE gear. So we mobilised quite quickly in response, basically due to what we were seeing internationally months prior to actually getting here on the 28th of February, I think is when we had our first COVID case. So we had seen what was happening internationally and needed to prepare and respond. But in actual fact, going from being in a from nothing happening within the community to suddenly a level 4 complete lockdown relatively happened really quickly. It didn't mean to say that our nursing workforce was any more prepared, because months prior we'd been talking about the nursing workforce shortages, the resource shortages, and a tired and exhausted workforce. So when we came in to respond to COVID, we actually had to mobilise at what was a really tired workforce. However, what COVID has taught us is that as an island in the middle of the South Pacific, we benefited in terms of the data and information that was coming out from places like the States, that the places that were being hit hardest. We were able to use our international collaboration to ensure that we were front-footing a lot of the research. So our Ministry of Health relied heavily on the information that was coming out of the WHO, which was was a bit challenging, to be quite honest. So a lot of our policies and procedures that were set up from the ministry were based on what the WHO were sending out, which seemed to be inconsistent with some of the research that was coming out of frontline hospital workers. So we were needed to receive information, analyse it quickly, advocate with or challenge the Ministry of Health around the development of some of their policies. So what we have learned is that we can no longer just think inwardly, and that our external collaboration has to go further than just health workers. it needs to be broader than what we had previously been looking. So it has opened our eyes, I guess, to both the value of international collaboration, both within the healthcare sector, but also wider than that. I mean, we are a union, so we do need to make sure that we are advocating for our members' rights during this process and access to health and safety legislation and protecting their interests. But COVID has taught us that we can no longer just sit within a health realm, but we must look broader than that. And we must make sure that we're a lot quicker in picking up relevant research and responding in a timely way to be able to be better advocates for both our nurses and also our patients.
Can I dig in a little bit deeper into that? Because that sounds very interesting. I had a question here about to what extent the pandemic has sort of exposed knowledge gaps both within your organisations and other, you know, so you've talked about the ministry, and I guess we're all sort of waking up to the fact, especially with so much fake news and other sort of nonsense coming out around the world. To what extent have you looked to kind of rectify those gaps, and what are you doing, especially Kerri, with your members, and Thijs with your nurses?
But for me, and I wanted to tap into that already, so thank you for that question. What we had was created scarcity in protective gear. So our government was in charge of purchasing face masks and gloves and aprons and all the materials abroad, and they were dividing it over the separate entities and organizations afterwards. And we found that the home visiting nurses, who are in our eyes the most vulnerable people, because you go in and out of people's houses, were at the bottom of the list with cleaners and teachers. And the government made out a simple statement: your nurses are just going to have to hold 1.5 meters distance from their clients, which if anyone worked for a single day as a home visiting nurse, this is completely impossible. So we reached out to an international organization that helped us with purchasing our own protective wear, and we bought over 4 million face masks in 1 month's time, which had to the result that we received large scrutiny from the Ministry of Health. But all the independent organizations, especially in home nursing, wanted to collaborate with us to share in this wealth of protective wear where there was scarcity on the backhand. That there have been questions at the ministry and the House of Commons after this, and the Buurtzorg way of working has been since then expanded internationally. So we have a partner in Australia, and they've tried to do the same. Our partner in China is on the opposite side, so they have a lot of protective wear at their hands because of the manufacturers. And they've been helping us getting to the source of these masks and dividing them over the European and Western countries where they can get a fair price and we get our protective wear. So that is a large part of it, which has also involved non-health related professionals to raise awareness for this. And what I've seen in a lot of countries also since then is the clapping appreciation for the healthcare workers, but it's very quick forgotten about, and I think the biggest problem here is that one time clapping or smacking on a pot with a spoon is not enough. There needs to be constructive improvements in the working environment of the nurses and other healthcare professionals, and also in the payment system. I understand that for a lot of countries this is a utopia, and we have to get there slowly. But I hope with an international collaboration of unions of nurses like yourself, Kerri, that we can create a sort of movement that internationally we say this is what's going on constructively around the planet, and it needs a solution now before it gets even worse than this. So those are some of the things that are on my mind these days, and I'm sharing knowledge and ideas outside of the World Health Organization, but specifically on the front of nursing, community nursing, and public health can be very important.
Yeah, Kerri, maybe we could have just a frank conversation about, tell us a little bit about your nursing members' experience. You touched on it a little bit with PPE, but also, you know, a lot of this plays out in the media, and it's very apparent that some people have been playing politics with it. So and maybe we can discuss sort of the levels of trust and respect between the likes of the DHBs and frontline staff who are feeling very exposed and mentally stressed.
Yeah, sure. I think for us, what connected with me is I was on an international call with some nurses from the States, and they looked shattered, absolutely shattered. And from one nurse to another, you know, your heart goes out when you can feel another colleague that feels powerless. And what she said is that she sat in the tea room and she looked across to another colleague and they felt doomed because they didn't know how can they combat the virus when they don't have access to adequate PPE gear. Now, what this meant to us is that the very first thing we needed to fight for was adequate PPE gear. What we had on the 1 o'clock, and we talk about the public announcements every 1 o'clock in the afternoon from the Prime Minister and Director General of Health and the police. So what we were hearing was that there is adequate PPE gear, that nurses have to be safe, feel safe, that we have to mobilise and move fast. If we want to contain this, we need to move quickly. So what we were doing is we were sending nurses into a healthcare system, and what they were reporting back to us is that they didn't feel safe. They couldn't feel safe because they didn't have access to adequate PPE gear. So this is with inside district health boards, which is usually the second line of defence. Primary healthcare and community were the ones that were out there doing a lot of the initial swabbing screening, and they didn't have enough PPE gear. We had palliative care nurses that were going into homes that were needing to go back to the office and make up their own masks out of laminate paper. So what we were hearing was inconsistent with what the Director General for Health was telling us. So we kept on saying there needs to be something, there is something not quite right here. When you've got frontline essential workers and a Prime Minister that's saying we need to be kind to people, well, kindness is also about protecting the interests of the healthcare workers. So we kept pushing at this issue. Then we had cluster outbreaks happening in aged care, still reporting lack of PPE gear. So what we did is elevated the issue and called for the Director General to have an independent review of access of the supply and demand to PPE gear. Now that exposed, once we got the Auditor General in and the Ombudsman to look at the aged care clusters, what that identified or vindicated was the concerns of nurses were vindicated. There was certainly PPE issues. There were certainly issues with supply and demand. There were certainly issues with adequate storing and quality and access to PPE gear. So what it did create is it meant that the nurses were empowered to ask more and to come out stronger, because certainly what was being projected outwards to public was different to what the experience was for nurses, but it was also inconsistent with what the Ministry of Health was sending out. So it did create a little bit of mistrust, distrust, and what we saw all of a sudden was an increase in PPE gear, a different way in access to N95 masks and the fitting of those. We saw more readily available PPE gear. But because, you know, what we had is nurses that wanted to go to work, wanted to help the communities, but were coming home at night and their husband or their partners had set up in the garage of their house or a tent in the shed or in the caravan. So they'd self-isolate themselves so they didn't reinfect or infect the family. They didn't bring the virus home. So we had nurses doing some extraordinary things to ensure the protection so they could go to work the next day, but also they removed themselves immediately from the family so they didn't bring any of the virus home, which actually meant that the nurses didn't feel safe and they weren't safe, because why would you go through those extraordinary things if you actually had a degree of comfort that you're going to be well protected? So what we ended up doing, and we saw a lot of healthcare workers become needing to go into isolation because they were they'd been in contact and COVID positive. So what we needed to do then is look at the legislation that protects healthcare workers when they are at work, and that's the Health and Safety at Work Act. And the unfortunate thing that we're still challenging is a weakness in the legislation and the obligation of the health and safety at work crew to protect and to investigate any outbreaks and the impact that that had on the nursing workforce to ensure its protection and safety. So we've still got, what COVID has done is unpacked a lot of the issues that we kind of knew. We now know that we were never prepared for a pandemic of this size. When we'd had previous epidemics and pandemics, our Ministry of Health had prepared for a pandemic as it was based on a population size back in 2005. But we're 19% more of a population since then. We've grown up since then. So we weren't able to respond to the current needs of the current population. And we had no way of future forecasting what would PPE gear look like? How would we need to measure and monitor its supply and demand to ensure the safety of both community, remembering that essential workers aren't just nurses and healthcare workers. So what we had is some gaping holes around our level of preparedness. But in saying that, what we did have is a government that once they realised their shortfalls, were prepared to remedy and make steps towards remedying the problem. And now, of course, we're in the second wave. And
if I may ask a question, Kerri, because you're from a union perspective, very involved in this. Was it difficult in your situation to get all the companies that work in primary healthcare and that do employ your nurses to get on the same page, or was it a natural movement after the first weeks of pandemic?
Yeah, what we never did is we never identified the workplaces, but what we had, the way that our health system works in New Zealand is that a lot of the services are devolved out in the community sector and aged care sector. So the distribution of our PPE gear actually went from the Ministry of Health to our larger district health boards, and it was their role to disseminate out to the communities. So what we had is a blockage in the flow down to these providers. So when we went out, we spoke in general terms. Certainly where there were cluster outbreaks and in some of the aged care facilities, we were able to focus in on some of the the relevant issues, but generally we spoke broader, so it didn't make identifiable some of the providers, and we were able to put nurses up. But remember, as you'd well know, that nurses don't actually like to take the public limelight and talk about, how hard they're done by their employer. So we took role away from them and provided that sort of distance and anonymity, but we're really strong advocates around access to PPE gear. So we called upon the Auditor General to do their work, the Ombudsman, and at the same time we worked with McGuinness Research Foundation to actually research our members as quickly as we could to see whether or not what they were saying was consistent with what the broader research was telling us. And certainly it all matched up.
Yeah.
I think it was really a critical time, and a lot of the radiologists and doctors were kind of stepping back and letting the nurses take the, not the limelight, but make the charge, because they were the ones that were actually out there doing a lot of the frontline swabbing and testing.
Yeah.
So it's a really respectful kind of way that we collaborated with the doctors and other health unions.
Yeah.
I'm really interested in to what extent you both think that this is just what the pandemic has exposed is actually the knowledge flow. So to a certain extent, you know, I know we've got two kind of different examples. The Buurtzorg model, which I should get Thijs to explain a little bit about how that's different from maybe in a hospital situation, but it's because in New Zealand, typically, I think it would be fair to say that we follow a very hierarchical approach, that the knowledge, it doesn't surprise me that the information coagulated at the top, and that, you know, that the DHBs, because, you know, it's a typical supply chain problem. If they're not at the front line themselves, the information isn't getting to the one place. So I guess I've made that as a comment. It's more a question to you both about how you both see the difference between a kind of a decentralized versus a hierarchical centralized system.
No, I don't know how familiar you are with our model, Kerri, but I will give a brief explanation. We started in 2006 with 2 or 3 self-steering teams in the Netherlands, and today we're market leader in the Netherlands in home nursing, with a lot of international ventures as well, and we focus on self-steeringness. So all the little nursing teams from 8 to 12 nurses, they're all their own little companies and they make decisions themselves, but they benefit of generic intelligence from the Buurtzorg company. So we have a framework that is pretty wide, and nurses can make within the team their own decision how they implement this framework, as long as it's financially sustainable and they keep the quality of care in mind, and also the centralness of the client. And this has been very successful because for a lot of nurses it's a very challenging and fun way to work in, because you're in the center of the community again. When in the 80s, 70s, 80s, the healthcare system in Holland already used to work like this. And then through the 90s and the 2000s, it got privatized, fragmented, segmented, and then a lot of commercial companies wanted to improve on efficiency and productivity and started sort of working production driven rather than client focus, and didn't have any outcomes on how many hours of care you would actually need to cure someone. So it became business. But in the pandemic, this had as a result that we had to be very careful. What can we integrate within the framework? So what is a non-negotiable for us as a company, and what do they want to do, and what is up to the teams themselves to make a decision. And even in a small country like the Netherlands, there was a big difference between the cases in the north and the south. The south was heavily impacted by Corona. In the north, there were barely any cases. So in our view, the Buurtzorg model could still work, that the teams in the different areas can make their own anticipation on the guidelines and the regulations that would be given from the government, but also from us as a company. But what we did, we started an Corona team. So one team that would have a meeting every day on the new information that we got from the government, international information, and from our partners internationally. So we got some information by the WHO, but we also have partners, for example, in Taiwan, who's not part of the WHO, and been very successful in keeping the virus out. So we would organize webinars and calls with these people. How have you been successful? How have you been dealing with it, and what is the response of your frontline staff? And we've involved all the teams in this. So we gathered information, provided them with the information to make the right decision themselves. Most teams started collaborating with other teams to make one COVID route. So you would only have a couple of nurses exposed to the possible cases of COVID in the area. So you'd minimize the risk of a lot of nurses getting affected. We would look at their personal situation. So is this nurse a father or a mother of 3 little children, and is a big chance of taking, when the virus gets taken home, it will spread over the entire family and then to their informal networks around it. Well, that seems not logical. So we tried to pick the nurses that volunteered for that. Oh, I'm just finished my studies. I live alone. I'm naturally in solitude after work anyway. So for me, it makes the most sense to pick up this route. And we actually had more volunteers for these corona routes than we needed because they felt committed to the safety of their colleagues. So this was the larger scale of the impact. Some of our nurses got sick, as people did everywhere, but the people that got sick were aware of the risk before they signed up to it, and their colleagues in the other teams and in their own team were extremely grateful because it could have been them. So it sort of created a larger empathy to each other's roles within the team, and I think in the end it made us as a company stronger because the shared entity of working for Buurtzorg and identity is greater and greater. So this is how we achieved this in Holland. Internationally, we are active in 26 countries now, and all these countries and partnerships we try to engage in what is successful in which culture and how can we move forward, helping each other out without interference of a local government or an international body of power. So it's all about information. We have 15,000 employees, and I think that with 15,000 employees, you also have 15,000 high educated, good opinions on what is a possible way to approach this. And we'd like to use most of them at least.
Yeah. It is quite a different structure than what we operate here in New Zealand. And as you said, Pete, it is more of a hierarchical. At the pinnacle of that is our Ministry of Health, which determine and set policy. And then we have large district health boards, which are situated across the region. So we have 20 of those across the whole of the country. And each of those come with their own unique way of administering and their unique priorities and direction. Our aged care sector is largely evolved or devolved down into private business model arrangements. And then we have primary healthcare organisations, which are also sort of private businesses on a bigger scale. So, and then we have peppered out throughout that palliative care services, blanket services or early childhood services. So we have a lot of services that are run by lots of different structures within our big health system. So when we get, and a lot of the criticism within the reviews that we've had and from nurses themselves have been the poor communication, the inconsistent and varied communication, which meant that what might have been sent from the Ministry of Health or Director General as a directive, it gets translated depending on which area you work in. And so there wasn't the consistency necessarily of infection prevention controls. There was inconsistencies around when masks can be worn and when headgear gets worn and et cetera, et cetera. So that created a whole lot of discontent amongst health professionals because there was not one clear direction coming out. And I know that when we went into level 4, which was basically a complete lockdown, with just essential workers going about their business. And what we did have is that the providers, the doctors were still, or the healthcare workers were still feeling very uncertain about what was happening. It took us almost 2 weeks into that lockdown until we started to see clearer policies and guidelines coming out of the Ministry of Health. But in that really critical time, when there's a state of emergency and you're wanting some clarity and some really clear direction, to have to wait for 10 to 14 days for some policies to come out or some WHO directives eventually to come out, it meant that we were dealing with the unknown. And what we were seeing every night on the 6 o'clock news was how many deaths were happening around the world. And so there was that risk. We felt like health professionals felt they were putting themselves at risk with not really getting any clear direction and not really knowing the transmission of the virus or how to deal with it or what was best practice. So it created a lot of tensions amongst the providers, but the complexity of the way that our healthcare system works within such a small country is what created a lot of the challenge.
No, I sort of get what you're saying. With the fragmentation comes a lot of uncertainties, and if there's too many players around the health support system of one individual, it makes it very, very complex to find out how and where do we spread, how do we stop spreading this virus. So this is one of the key pillars of the Buurtzorg model already, and this is where I think our success has also shown in a pandemic, that we try to minimize the amount of health professionals that visit a client each day or each week. So this is also towards mental health. It's very important. And the system, how it was before we started in Holland, there was some clients that received 30 to 40 health professionals in their own house on a monthly basis. And for someone with dementia or cognitive issues, it's the benefits that you get from the physical maybe improvement, that from the interventions of the professional, goes all overboard with the deficits of the mental health. This was one of our motivations to change the entire system around this, and to really focus on this, that a suspected case of COVID-19 would only ever receive one professional in their home with the right protective care, really takes it down to, okay, if it spreads through this client, we know exactly this nurse is the only one who can be infected in our company, and those clients afterwards who were also already suspected clients, because that's the corona route, may have been impacted in hindsight after as well by this client. But to minimize the exposure of everyone, it has been, I think, within our company, proven to be successful again. So maybe for New Zealand in the future, moving forward, this can also be a good way of restructuring the public health system.
I'd be really interested to know, Kerri, what you're kind of doing to try and solicit information coming back upstream from, especially in communities, rural communities, etc., in terms of like, you know, the nurses are the frontline staff. You know, they are the ones right at the where it's actually happening, and this seems to me. Are there current sort of facilities or abilities to be able to get that information where it actually counts and back upstream through the DHBs into the ministry, or is it a problem of the whole structure?
I think it's a problem of the structure and the funding formula that it's set, and how that is fed down through the system to get out to the rurals. There were stories of people that lived in rural communities. I mean, once we went into lockdown and we were servicing the central business areas, basically, who was going out to the rural communities? And a colleague of mine said that she made a really incredibly long trip to go out to this community that she lived, that she knew was pretty much isolated, but there was a small community, and she referred to them as almost living in like a shanty town, a makeshift town. And so we have to remember that some of those people that live out in the communities are our most vulnerable and are not necessarily have the same access to running water or electricity as what you might have in a town situation. And she told me the story about how they've been trying for a long time to get a needs assessment done and to get services for this woman that was quite debilitated. But once we went into level 4 lockdown, services came like that. So we've got to find a mechanism that we don't complicate things and access to services which diminish their quality of life just because of bureaucracy. We've got to make sure that we're living a pandemic all the time and we free up services to get to where they're needing to do. But at the moment, we haven't been able to have that really robust conversation with the ministry to say, just because of COVID, we shouldn't have to, open up the floodgates. We should actually be enabling that to happen to ensure that everybody has access to quality of life. But those really challenging conversations are those things that we haven't actually had yet. And our health and disability system is under review. We've got a Heather Simpson report that's out. So we've got to take, and I think that document's still out for consultation, so we've got to take the time to look at doing things different and not just doing more of the same thing. Bad.
Yeah.
I mean,
well,
yeah.
I mean, a lot of the, just an observation with the Simpson report is that while it's sort of addressing these long-term problems that we had, it still seems to be slanted towards a highly bureaucratic solution and approach. There's all this talk about strong leadership. Even the Maori Health Authority just seems to me, and that, as you would know, is problematic in itself. And once again, it seems like rather than enabling and empowering the communities to help themselves, there's still quite a paternalistic sort of approach to community health.
Yeah, definitely. I think what's obvious through the Simpson report is the power and control doesn't shift or change. It still remains within the structures. It might just have a different name. And if we're really going to embrace change, especially on the tail of COVID, then we should look at different models of care and not just the same models of care. But I take your point that you make. We've been talking a long time now that nurses' scopes of practices are limited by the policies that are put out from government. So we don't just need a clap. We just don't need a minister to say, nurses are the backbone of a healthcare system, and then turn around and actually put in structures that oppress the voice and freedom of nurses to be able to work to their fullest potential. But we do need to recognise nurses were the front line in the combat to COVID. How do we create it so that we can ensure that they respond, that they have their own autonomy, and maybe work in smaller teams that are more patient focused or patient centric? And how do we recognise the skill and expertise that they bring and pay them what they're worth? That's we have such a huge workforce that we underpay the hugest workforce that make a big difference.
I think you touched the spot there, and what I think is important, if you decrease the hierarchy, money will become available to pay the frontline staff accordingly, and I think that's the essence of this entire story. Keep the quality and the knowledge where it is with the frontline staff, and pay them accordingly so they actually get paid to care.
Well, this is, I think, it's a cultural issue that requires cultural evolution to acknowledge that you can't substitute knowledge with power and control. And actually, knowledge and local expertise is much more valuable than power and control. So and if you look at the language that we encounter in the media and from the government, whenever that is about getting things under control, it's actually an acknowledgement that there's a complete lack of understanding of the role of knowledge and expertise in this context here.
That's right.
Absolutely. Good.
Well,
unfortunately, I have to enter another meeting very soon.
Yes. I wanted to say
I have
one
little
thing
time.
before you go.
Sorry?
I wanted to just put one idea in your mind before you go. Jorn and I, we are working on a project around a community co-designed healthcare solution, and we're not prejudging it, but we would like to get your help and Kerri's help in terms of like trying to find a new way that we can kind of seed a community-driven health solution, especially you know, in rural and Maori communities. You know, I think we need a totally new approach that is led by and co-designed by the people. So I don't know if you are both interested in this, but we would like to get your help on it.
No, I'm always willing to help and give advice. If there's a certain structure to it, please let me know, and then I'll do what I can. I thoroughly enjoyed speaking to you, Kerri, and hearing your ideas. If that means that the union, the New Zealand Union of Nursing Body, is also involved, it'd be very persuasive for me to join it.
Fantastic. It's been great. It's been great catching up. I'm happy to be involved and to suggest people that might also help advance that work. But yeah, it'd be great to catch up one day and connect up organisations.
Yeah, absolutely. All right.
Excellent.
Thanks to all.
Thank you, Thijs. Thank you, Kerri. It's been fascinating. We're putting together videos of this and transcripts because we think that there's valuable information for people in the future. So thank you very much to both of you for giving us your time.
Bye-bye.
Good evening. Bye-bye.
Bye.